is now being recorded.
Git, काही complaint असेल तर सांगा. Hello, good morning to everyone. Today we are learning the multi-drug resistant tuberculosis and its diagnosis. I am giving this lecture in two parts: its diagnosis and then the management. You know what is now today, day by day, the tuberculosis resistant cases are going on increasing, and from this chart you can recognize that the incidences of in the global of the drug tuberculosis is 100 lakhs in global, and in India 27.4 lakhs. Also mortality is also increasing due to the HIV TB cases are also increasing. Uh, from this graph, you can make out now day by day means in the from 2012 to it was up to 2019. The presumptive drug-resistant tuberculosis cases are also going on increasing. These bar charts are the cases of the presumptive drug-resistant tuberculosis. Then previously there was for diagnosis of the drug-resistant tuberculosis, the CBNAT machine, that is the cartridge-based nucleic acid amplification test. These machines are very less in amount but quantity. But now because of the problem is more, hence the machine number of the machines are going on increasing. Previously it was only there are 18 machines, but in the 2018 there are 1100 and 80 machines are all over the India. Then there are cases of this line, that is extra tuberculosis, means extensive drug resistant tuberculosis. Previously these cases are also incidences less, but it is now also going on increasing. Why this type of the problem occur, and what is the how we should diagnose and treat this type of the cases, we will see. The percentage of the new TB cases with the MDR tuberculosis or rifampicin resistance tuberculosis all over the world is shown in this graph. And in India, about the new cases, the incidences is about 3.3 to 5.9%, and the percentage of previously treated tuberculosis with the MDR or rifampicin resistance is also increased. It is about 10 to 29 percentage. Now we see the what are these causes of the drug resistant tuberculosis. Why these figures are increasing? Usually it is known as that this drug resistant tuberculosis is man-made phenomenon, and there are main three causes of the drug-resistant tuberculosis. First is the microbial, second is the clinical, and third is the programmatic. We will see one by one. What is microbial? There is the genetic cause, means there is some mutation occur in the organisms and they are responsible for the drug-resistant tuberculosis. Now, second is the clinical, that is there may be inadequate or poorly administration of the treatment. And programmatic means the government is providing these drugs. If there is poor organization of the this TB control program, it is give for remember you see this table. There are three categories. Microbial, I will tell you later on the which genes are responsible for particular drug. But this three column, that is the inadequate regimen. Sometimes what happen, the patient is taking treatment and he is not getting response. The doctor or he himself sometimes the inadequately he add one medicine and omit one medicine. That is an inadequate regimen, unsupervised regimen, absence of guideline, and non-compliance means patient is not taking proper treatment also, or inadequately training of the health staff. They are responsible for the causing the drug resistance tuberculosis. Second is the due to the drug also there is development of the drug resistance. First is the means inadequately supply. Means if the drug is not available, then resistance will occur, and poor quality of the drug. Means non-availability drug and poor quality. Many times all these drugs which are supplied by the government, they are usually very nicely qualified, and they are, if there is a poor quality of the drug, then they also cause the drug resistance. Second is the wrong dosage or combination. Means there is the some regimens, and if also doses, I have seen some well-known doctors also, they are not giving proper doses of the anti-TB drugs, and because of the less dose or according to not, they are not giving the treatment according to the weight, and hence there is development of the drug resistance. Third factor is the patient factor, that patient is not taking properly treatment, that is inadequate drug treatment. Usually what happens, this TB treatment, the duration of the treatment is about 9 to 12 months. Primary drug resistant is TB sensitive, this treatment. The patient usually 9 to 12 months. But what happens, usually patient take 1 to 2 month treatment. He feels better, and then he stop of his own, himself, without any doctor advice. That is the main cause, inadequately drug intake of the drug intake. Then poor adherence, lack of the information. He doesn't know the how much many duration the treatment should be taken, or there is non-availability of the free drug. Sometimes patient get toxicity, we have to remove the rifampicin or any other drug, and then these drugs are not available. Then also patient can't take that tablet also. There are some social and economical barriers, sometimes malabsorption of the drug. These are the patient factors which causes the drug resistance tuberculosis. Now, what is the drug resistant tuberculosis and what are the different types of the drug resistant tuberculosis according to the RNTCP? Now it is known as the NTP. RNTCP means
Madam,
Research
system is
National
not showing.
Tuberculosis Control Program. Can I, am I audible to you?
Ma'am, exit Siddesh request to join meeting.
Okay. Admit करते हैं. Now we will see the different types of the slides are moving. You can see the slide,
Yes, ma'am. Yes, ma'am.
Chaitanya.
Yes, ma'am.
Okay. Now we see the different types of the drug resistant tuberculosis. What is first? What is drug resistant tuberculosis? When the result, it is the from this drug sensitivity test should be done from the RNTCP accredited quality assured laboratory. Other lab reports, we are not approving that. We are not miss. These results should be accurate from the accredited lab. The first type is the MRTB, means the monoresistant tuberculosis. Monoresistant drug resistant tuberculosis. What is mean by that? A patient whose biological specimen is resistant to the first line anti-TB drugs. That is the monoresistant resistant tuberculosis. And H resistance means, now it is also one part of the monoresistant, but here the patient sample, biological sample, is resistant to INH. That is INH, and it is susceptible to the rifampicin. Only the specimen is resistant to the INH, hence it is the H monopoly or H resistant tuberculosis. Then polydrug resistant tuberculosis means the patient whose biological specimen is resistant to more than one first line anti-TB. What are the first line anti-TB? INH, pyrazinamide, rifampicin, and ethambutol. These are the drugs. When the patient specimen is more than the resistant to the more than the two primary drugs, then it is the polydrug resistant tuberculosis. Then there are another, that is the only rifampicin, that is the RR. rifampicin resistant tuberculosis. His biological specimen is resistant with Mycobacterium tuberculosis resistant to the rifampicin only, without resistance to the other anti-TB drugs. You should remember this. Then what is the MDR? Now here, what is difference between, but it is that mostly that rifampicin resistant, previously it was presumed that it is the multi-drug resistant tuberculosis, because when the patient's specimen is resistant to the rifampicin, it is presumed that it is resistant to the INH also. But now there is the division different. Now what is MDR tuberculosis? The patient whose biological specimen is resistant to both INH and rifampicin, or without resistance to the first line anti-TB drugs. Other drugs, the sensitivity is not done, but INH and rifampicin sensitivity is done, and it is resistance. It is the MDR TB. And now the previous there was also pre-XDR. That pre-XDR means it is a case of the MDR but resistant to either the quinolone or second line injectable drugs. But now this term is now not used. Now we use the XDR, that is the extensive drug resistant tuberculosis. It is a patient of MDR TB but whose biological specimen is resistant to fluoroquinolone and second line injectable drugs, that is the kanamycin, amikacin or capreomycin. Now these are the different types of the drug resistant tuberculosis. We will see how this DR TB means drug resistant tuberculosis cases should be found, how they are should diagnose the cases. There are the different types of the patients in our society, and they are under two groups. That is the presumptive drug resistant tuberculosis and vulnerable tuberculosis. Well, in this presumptive tuberculosis, it refers to the following patients where the all notified tuberculosis. Now it is previously the drug sensitivity test was done in the suspected cases only, but now universal DST means all type of the notified tuberculosis patients, either they are diagnosed in the public sector or the private sector, they should be they should be treated as a presumptive drug resistant tuberculosis, as the incidence and prevalence of the drug resistant tuberculosis is going on increasing. Then the second type of the presumptive drug resistant tuberculosis is the follow-up positive, means a patient is taking primary drug of the treatment anti-TB drugs and his follow-up symptom is positive, means there is treatment failure on the standard first line TB treatment, first line treatment. Then also this is the presumptive drug resistant tuberculosis cases, or sometimes patient is resistant to only H monopoly regimen. Then any clinical based patient is taking proper treatment, but still there is the no good response, clinically no response. That is any clinical non-responder, including it is usually in the pediatric also. Means pediatric, there is no sputum examination, we can't do gastric lavage, we have advised. But sometimes patient, we have started the treatment also, we are clinically suspecting patient having pediatric pulmonary tuberculosis, but he is not responding. Then again you think the drug resistant tuberculosis. Then how you should case find it, they are divided into, I told, the presumptive drug tuberculosis in first. The second group is the vulnerable group. Vulnerable group is any group of the people in which the prevalence or incidence of the TB is significantly higher, like in our India the prevalence is very good, or incidence of the TB is very large. Hence it is a vulnerable group, and we should see all the cases of this vulnerable group. Then for diagnosis, once you have in these two types of the, I will show you later on the algorithm for the diagnosis of the drug resistant tuberculosis. But there are different tests. There are different methods for the drug susceptibility testing. Means when if you suspect in this vulnerable group or this group presumptive drug resistant tuberculosis cases, patient is not responding, or failure cases, relapse cases, then you should send a sample for the DST, that is the drug susceptibility testing. And there are different types of the methods for the drug susceptibility testing. And main two types are the genotype, this is genotype, and second is the phenotype. And you should know the difference between the genotype and phenotype. The genotype is now recent, it is the rapid molecular drug resistant testing, and we get the result at earliest. Within 2 hours, we get the reports. But in the phenotype, what happened? It is the gold standard method, but its duration is very more. It is about more 1 month or 2 months also. It is growth based. We have to culture the bacilli first, and then we have to test for this drug sensitivity test. Yes, it require more time. And DST for first line drugs means for HERZ, that is INH rifampicillin that is the levofloxacillin, moxifloxacillin, kanamycin, capromycin, and other drugs like the linezolid, clofazimine, bedaquiline, etc. Now, in this rapid molecular test, that is genotype, there are again two types: nucleic acid amplification test and line probe assay. Now, what is nucleic acid amplification test? Here, the only the genetic material is extracted from the bacilli, and they are get amplified, and hence we get the copies, multiple copies are done, and hence we get the immediately report. It is all computerized also, and there are again two types of the net nucleic acid amplification. First is the cartridge based, that is CB net. Usually you heard also this word frequently. CB means cartridge based net, and sometimes without cartridge also cheap also there is, that is chip based, that is also known as the true net. These are the two types. Also there is one ultra net also is now coming. This they are giving the report within 2 hours. In line probe assay method, again there are two types. The first line, like LPA for first line and LPA for the second line. First line means for the first line anti-TB primary drugs, and second line means all secondary. Now, what is the main difference between the phenotype and the genotype DST? That is, the in phenotype culture of the organism is required, and then the DST will be done. But in genotype, culture of organism is not done, is not required. Only nucleic matter, that is nucleic acid, its amplification is done. And in the phenotype it requires for, if we want to culture in the solid media, that is solid culture, it requires about 6 to 8 weeks, means about 2 months at least, and for liquid culture 2 to 4 weeks. But it requires only two to in the genotypic 2 to 72 hours. Now the test different are the backtech. MGIT means mycobacterium growth indicator test, that is 960. Our other back T alert and the solid LJ media. Solid LJ media culture method is the gold standard method, but requires more time, 4 to 8 weeks, 6 to 8 weeks. And the test under the genotype are the line probe assay test, line probe assay for the second line injectable drugs also, CB NAT and the ultra GB NAT. Now, these are different methods, but which is the drug, which choice of the diagnostic technology? Means the first choice is the, for diagnosis we should use the NAT and LPA. NAT means nucleic acid amplification test is the first choice. Then liquid culture means if the patient is diagnosed and we have to follow up the patient, you can give the liquid culture isolation and LPA DST test, or liquid culture isolation and liquid DST also. This is the third choice. Then I have already told you the different means duration turn or a time for this all type of the test. Now, it is also important how you should collect the sample for the CBNAT, and it is very very important which sample you should send. Now, about 5 ml, 2 to 5 ml sample is required. Preferably, it is a mucopurulent. It should not be saliva and not heavily blood stained. Means if patient we are sending any type of the fluid, body fluid, means you can send the if extrapulmonary tuberculosis, CSF also, pleural fluid also, abscess also. But if it contain blood, it will not give the proper result, or sometimes the results will false also. And then this should collect the sample in the conical 50 ml tube, conical tube, and that is tube is known as the falcon tube. Falcon tube, I will show the picture of that falcon tube. The specimen should be transferred to the NAT or the CDST, means culture drug sensitivity test laboratory as soon as possible after the collection. You should not keep it in your in the, with the in the room temperature. Otherwise, the reports will be false reports, and there should not be delay. You should, if there is some delay because of unavoidable cause, then you have to keep the sample in the refrigerator. So this Falcon tube also I will show. It is the 50 ml container conical bottom tube, and it has the three layers packing material also. You should name the patient's name there under that tube. Then excuse me. Then you have to pack it in the thermocol box or ice shell pack. Preserve the temperature 20 degree for minus 20 degree for the 48 hours. Then request is for testing the biological specimen. Also form, you should fill that form. And polythene bags or tissue paper roll as absorbent, and you should use the brown tape for the packing the box. Permanent marker pen means the name of that patients will not get means it will remain there, and label it properly. There are some steps also. This is the Falcon's tube, and these are the different steps. You should wrap, you should name the play, give the name on that. Then this is the process of packing the this Falcon tube in the thermocol box, and then you transport with the personally with the relative or with courier also you can send to the nearby your net center. Then this is the thermocol box and transport box if the sample is sent far away. Then I will tell you there are the duration time required for each test. Now, if patient having the cough and we want to do the ZN staining, we will give the we will get the report within 1 day or after a few hours. But there is some sensitivity and specificity. So also subjective errors are also present there. And second most the advance is the fluorescent microscopy, but it is very costly and hence usually we are not using this. And third method is the solid culture method. It requires 6 to 8 weeks. Liquid method requires 42 weeks. It is given time duration. I already told you. Now, what is the algorithm for the diagnosis of the? Now, if you are suspecting tuberculosis, drug-resistant TB patient, then presumptive or the vulnerable group, all this group of the patient, this algorithm you should keep in your mind very properly. Now, presumptive tuberculosis, already I told the patient living with the HIV, then extrapulmonary tuberculosis, smear negative, or you are suspecting and smear negative, but X-ray is the suggestive of the tuberculosis. They also come in the presumptive tuberculosis, vulnerable population also, and contact with the drug-resistant tuberculosis. All these type of the cases are under the presumptive tuberculosis. And non-responder means who is taking the treatment and not getting the good response. They also come and all notified new diagnosed tuberculosis patient. All this type of the patient sample you should send for the NAT, either CBNAT, ultraNAT, that is the nucleic acid amplification test. Now there is two effects, results of the net. Either it will tell you the mycobacterium tuberculosis detected, not detected. If detected, then it give you the whether it is rifampicin resistant or rifampicin non-resistant. If it is rifampicin resistant, we think that it is the MDR tuberculosis. But we have to send a sample, means we have to take the two samples, and we have to send a second sample for the LPA for the first line, second line, that is first line and first line and second line drugs DST. But and you should start the treatment of the MDR drug resistant tuberculosis. But if the patient's sample is resistant is not detected, then you should send a sample for the first line LPA, means other primary drugs, that is INH mostly. Paracetamol we are not still not started, Ritambitol also, but the INH is very important, and it gives result INH resistant detected or INH resistant not detected. If it is INS not resistant detected, then you continue the primary drug of the treatment. But if INS resistant detected, again you send the sample for the second line LPA and also DST for the paracetamide. And again the DST for the moxifloxacillin, linazolid. These are the second line of the treatment. This is the algorithm how to diagnose the drug resistant tuberculosis. And it is why it is important first line, because INH if it is resistant, then it is cross resistant to the ethionamide also, and hence we should say the resistant to the INH also. If the PEP is resistant not detected, you have to send the sample for the first line LPA. Now these results, if the rifampicin resistant detected, you have to follow the, you have to send the sample for the first line LPI and for the for ethionamide. Also second line is second line LPA for the fluoroquinolone or second line injection. And these are the this DST to the moxifloxacillin, linazolid, clofazimine, and paracetamol, bedaquiline, they are means if you are suspecting, then you send a sample for that also. And if the rifampicin resistant is not detected, you have to send for the LPA, first LPA, that is H mono resistant detection, or for all H mono or polyresistant detected for the by the second line LPA, and fluoroquinolone and resistant to the pyrazinamide also. Now, in children, it is little difficult to diagnose the MDR drug resistant tuberculosis. Because there is no sample and we have to send the gastric lavage fluid, or the case definition of the presumptive drug resistant tuberculosis for the adult is simple, but the children it is difficult. However, the term probable MDR tuberculosis is the clinically diagnosed in the children, would be the applied to the children also, and bacteriological confirmation is not available, and the decision regarding the diagnosis and the initiation of the treatment is taken by the nodal drug resistant tuberculosis committee only, and we have to the manage the treatment according to the resistant pattern of that patient. Criteria for the diagnosis of the probable MDR tuberculosis in children with the sign and symptoms of active TB disease, who in addition have the following risk factors. That is, if you should suspect the MDR in children, if he is in contact with the known case, means if his mother is also suffering from the MDR, means he is in contact with the MDR TB, also means close contact with the person who died while on the treatment also, or close contact with the person who failed the treatment, which has not failure treatment, he is in close contact with the failure treatment, or in the relapse, or his relative is died due to the during the treatment, or failure of the first line regimen. If patient his child is taking first line treatment and there is no good response, then you suspect the MDR tuberculosis, and and then you send the sample, the gastric lavage fluid for the CBNAT, and this is the algorithm for the diagnosis of the drug-resistant tuberculosis in children. New child TB patient, and you should, if it is confirmed drug-resistant tuberculosis, you have to send for the DST also. And if it is confirmed drug-resistant tuberculosis, you treat the drug-resistant tuberculosis. If it is not confirmed, you have to contact with the infectious TB patient also. And this, then the source is a drug resistant. If there is source of the drug resistant tuberculosis, you think it is a probable drug resistant tuberculosis, and you do the DST on appropriate sample. Then if the drug sensitivity of source patient is not known, the source is the retreatment of the tuberculosis, or the child is failing first line treatment, then it is presumptive tuberculosis. Again you do DST, and then you have DST, or DRT, means drug resistant tuberculosis, and then you have to treat according to the results of the sample. This is little complicated, but what are the differential diagnosis of the drug resistant tuberculosis? Main, you should think if patient is not responding, other differential diagnosis is the non-tuberculous mycobacteria, that is NTM, and other names also known as mycobacteria other than tuberculosis, that is the MOT, or it is also known as atypical mycobacterium tuberculosis or environmental bacteria. These infections are very rare, but in opportunistic means they are non-pathogenic, but we get this type of the infection in immunosuppressed patient also. Hence, if there is no response and if you are thinking MDR, also think about the NTM infection. And there are different types of the NTM, the different names. It is special topic, but in short, I will tell you the large number of the mycobacteria. They are other than the mycobacterium tuberculosis, which are now being increasingly and recognized as causes the human disease. This non-tuberculous mycobacteria, also known as atypical mycobacteria, but the classification of this drug, of this organism species, they are Mycobacterium avium complex, that is Mycobacterium avium, Mycobacterium intracellulare, and they causes the main site of the infection is pulmonary lymph nodes disseminated disease. Their growth is slow. Mycobacterium kansasi also causes the pulmonary and disseminated disease. These are the different types, Mycobacterium sinoni, then all these are the different names of the Mycobacterium marinum, abscessus, and they causes the skin also, the involvement of the skin, then pulmonary, lung and skin as well as some, this Mycobacterium causes the skin, soft tissue, disseminated disease, and Mycobacterium staphylococcus also causes the infection to the lymph node. Hence, thinking the non-NTM tuberculosis infection is one of the differential diagnosis for the MDR drug resistance. Now, next lecture, we will see how the patients should be evaluated for the treatment, pre-treatment evaluation, which investigation we should do before starting the treatment, then what is the management of the MDR drug resistant tuberculosis, we will see in the next lecture. Thank you. चैतन्य ऐकू आलं का रे सगळं? Anybody can comment, anybody have any question? झालं का ते बघून यायचं व्यवस्थित. तुम्ही संपलं लेक्चर? हां? लेक्चर झालं? हो. मी बंद केलं स्टॉप स्टेरिंग.
असं रेकॉर्डिंग केलं नाही, रेकॉर्डिंग बंद केलं.
हा
रेकॉर्डिंग स्टॉप रेकॉर्डिंग